shout out to the Sierra Health Foundation and our sponsors, Novo Nordisk, Boehringer Ingelheim, and Genentech. We have a fabulous speaker with us today who works on a high technology project to improve patient outcomes across multiple UC campuses. I will now turn the meeting over to our co-chairs to start the introductions. They can introduce themselves. Dr. Jose Arevalo from Sutter IPA and Pamela Leish from HealthNet. They will do a great job leading the meeting today. I'm under the weather, so if I don't spend time talking with each of you, you'll understand why you don't want to catch what I have. And with that, I'll give it to Jose. We'd love to have introductions around the room.
Well, thank you for Hattie for being here. I know you don't feel well, and thanks. This is a special effort. And so, what we wanted to do, first of all, I'm Jose Arevalo, and I'm the Senior Medical Director for Sutter IPA, and also one of the co-directors here. And I wanted to thank you for coming out here and hearing our monthly presentation. This is going to be very interesting. I'm also going to apologize because I have to run to another meeting right after Dr. Lindeman. But one of the first things we wanted to do is to actually ask the audience to self-introduce yourself and tell us who you are and what you do. And if you could just spend 1 second telling us what you'd like to get out of today, that would be very helpful. So I'm going to ask Jessica to start. Do you mind?
Good afternoon, Jessica Nunez de Gaza. I am soon to be the Director of Coordination for Chronic Disease Prevention at the California Department of Public Health. We recently published, after many years, California Wellness Plan, and very proud to answer any questions regarding it. I know Jose in the past mentioned at some future point to maybe bring this up as part of the discussion here. And I just wanted to let you know a lot is being formulated right now at the state, and so not a lot of information yet in terms of implementation, but your ideas are welcome. Thank you.
My name is Martha Garrett. I work for HealthNet. I represent Northern California for health education programs, and I'm leading the statewide cardiovascular health initiative, which is new for HealthNet. It's a comprehensive health education program for our members in the community statewide that will be launched in the fall.
Sang-Mi, could you go next, please?
Sure. Hi, I'm Sang-Mi Oh, the American Heart and Stroke Association. I work on our health equity multicultural initiatives, and one of our focus areas is around retention. So, and that's a national initiative that we have launched.
And I'm Alicia Fu. I'm with the California Department of Public Health. I'm a medical consultant. Prior to this, my current position, I actually led the heart disease and stroke program for the state of California.
I'm Christine Curry. I work at Genentech's medical side of the organization. I'm a pharmacist by training, and the area that I specialize in is quality of care and health outcomes and how we can make improvements there.
I'm Maureen McKinnon. I'm the Regional Affiliations Officer for UC Davis Health System. I work with Ann Rice, the CEO of the hospital, and also Dr. Nesbitt. Used to be at DMHC as a deputy director over there. I'm a nurse and an attorney by profession, and I'm very interested in telehealth, and I came to hear Dr. Lindeman's presentation because I really think that's the future of healthcare is health technology.
I'm Eva Krejcinovic. I'm with United Care Health. We're a national Taft-Hartley, which is a fancy way of saying union health plan for workers in the hospitality industry. And I'm mostly interested in applications for technology for immigrants and the working poor.
I'm Linda Ashton. I'm a pharmacist with Health Services Advisory Group. I just joined them in February, and I'm really looking forward to working with this group and all of you who work in the areas of diabetes and cardiovascular disease, and so we could leverage all of our resources to meet our goals for those patients.
And I work with Lisa. My name is Jennifer Wojtkowski, Director of Care Transitions, and my big project at HCP is improving coordination of care in communities throughout California and reducing readmissions.
I'm Sharon Myers, and I'm a nurse at UC Davis Medical Center, and I work in a department called Health Management and Education, and I'm a heart failure care manager. And I'm here today because I'm always interested in learning more about how to help patients better manage their heart failure and stay out of the hospital.
I'm Don Hufford. I'm the Chief Medical Officer at Western Health Advantage.
Jerry Jeffrey, California Chronic Care Coalition.
Hector Rodriguez, UC Berkeley School of Public Health.
Everybody, Yuki Valcarne, I'm from Blue Shield of California, and I head up all of the clinical and provider integrations for the company, focused on really at the end of care, point of care capabilities, and today I'm hoping to
Could you
meet
speak up, please?
Oh, I'm sorry. I'm hoping to meet some of you and also learn kind of more about the organization and where things are going. Happy to be here. Thanks.
David Matsumura. I'm an account executive with Novo Nordisk.
Hi, that's Sandy Merrick, also with Novo Nordisk, account manager working with local payers in and around California.
I'm Jennifer with Capital Health Network.
Amy Krause, Patient Advocate of the State, California Office of the Patient Advocate.
Warren Burns, UC Berkeley School of Public Health and Grace Presbyterian Church in Sacramento.
I'm Kate Weber from Barrier Ingelheim, currently working with health systems around care coordination around diabetes. I'm very interested in how we use telehealth and incorporate that.
Hi, I'm Jen Vandermay. I'm the Care Coordination Ambulatory Director for Center Health in our Sierra region. I have embedded case management teams in the physicians' offices, and we just recently included pharmacy in that role. So I'm always interested in learning more about technology and how we can be more efficient in what we do with our patients.
I'm Ralph Goldinger. I'm president of Sutter Independent Physicians, and I'm here to be sure that Dr. Revelo is doing his job.
I'm Dr. Brian Hayes, the Associate Chief of Staff for Northern California VA. VA is always interested in using technology to better our care of our veterans.
I'm Juliana Burton, and I'm the director of the ambulatory care pharmacy side of things at UC Davis, and I'm here to learn lots of great new things and how I can implement them with our pharmacists.
Hi, my name is Tina Ling, and I am the pharmacy resident at UC Davis Medical Center in the ambulatory care setting.
Hi, I'm Jim Ellsworth with Capital Health Network.
Hi, my name is Shannon Nesky. I'm the Regional Program Coordinator for Southern Neuroscience Institute.
Hi, I'm Barbara Welcher. I'm the Stroke Coordinator for Southern Medical Center Sacramento, and I came here to learn more about the technology with heart and diabetes to see if it applies to stroke.
I'm Heidi Bench. I'm the Sutter Health Clinical Pharmacy Coordinator for the Sacramento and Sierra region for the Sutter Medical Foundation, SIP, Sutter Independent Physicians, and Sutter Medical Group. So I'm here to learn how pharmacy can better support them and their task for population management and the things they need to do to improve care.
She's also here to make sure I do my job.
Okay. So I'm Gil Simon. I'm the founder and medical director of SAC Family Medical Clinics. We've just completed our 25th year of service to the Medi-Cal community of Sacramento through our 9 clinics and 20 providers. And I'm here to see whatever can be learned that can be applied to the Medi-Cal community.
And I'm Bill Remack. I'm with the California Chronic Care Coalition. And we've been working on a program having to do with health information exchange. Very interesting. We're keeping it under wraps until it's time, prime time. While working on the steering committee, we deal with a lot of issues that having to do with people with chronic conditions. In my spare time, I'm chairman of the California Hepatitis C Task Force and the National Association of Hepatitis Task Forces and the World, on the advisory committee of the World Hepatitis Fund. So I do that in my spare time global initiatives and so forth. So, and right now I'm today's videographer. So,
You know him as the Uber Right Care volunteer.
so remember, you're on camera. Okay, thank you.
I can't beat that, Bill. Liz Helms, President of the California Chronic Care Coalition, partner of the Right Care Initiative since 2009. We believe this is the way to change patient care and get to the quality and getting patients engaged and knowing how to better take care of their health. And we are looking forward to the technology piece because that is critical in improving the whole team and the missing pieces that I know you have so eloquently worked so hard on. So thank you.
I'm Carla Verdi. I'm with the Project Assistance for the Right Care Initiative.
Debbie Nixon, I'm with Health Services Advisory Group.
I'm Alan Erdl. I'm the CMO of Mercy Medical Group here in Sacramento. I'm here because Jose told me to. And my objectives are to learn what's going on and to meet folks and to behave well enough to be asked back. So that's
I'm buying coffee for the next year for Alan. And I wanted to also have an opportunity to introduce Mary.
Okay. Mary Ferguson, I'm the Chief Medical Officer for Health Services Advisory Group, the Medicare Quality Improvement Organization. We are sponsoring partly the Right Care Initiative as well, part of the big partners here. And we think that this is the right forum for activating our physician leaders and learning about how to manage chronic illnesses, especially targeting the million hearts focus, which is hypertension and hypercholesterol and smoking cessation and using aspirin.
Well, thank you. Well, before I turn it over to my esteemed co-director, Pam, I wanted again to thank you and remind you that this is a great opportunity for us to kind of lay down the swords at the door and to share best practices, because at the end of the day, what we're really interested in is improving cardiovascular health in the Sacramento region and working together across the sort of borders around our various institutions. So this is really exciting to continue this. We've been at it now for over a year and a half, and we thank you for your participation, and I think you're going to enjoy the program. So now I'll turn it over to Pam.
Thank you. Can you hear me okay? I'm not talking too loud. My voice carries a little bit. Well, I'm really excited to introduce our next speaker, Dr. David Lindeman. He is the director, and I'm going to read this out because I was at a conference last week where a colleague of mine was introduced as having an MBA in chemistry. That was an interesting one. It's like, how do you get that? So anyway, he's the director for the Center for Technology and Aging, and he's the director of healthcare for the Center for Information Technology Research in the Interest of Society, also known as CITRIS, at the University of California. And prior to his current role, which he's been in since 2013, he actually was the founder and director of a company called Mather Lifeways Institute on Aging, which was in Evanston, Illinois. Prior to that, held some positions at Rush University in Chicago, and also UC Davis, and actually got his BA from State University of New York in Binghamton. I said that wrong, Binghamton. And also his PhD and his master's in social work and social welfare, health services research, and gerontology from UC Berkeley. So today he's going to speak to us on the technology-enabled solutions for congestive heart failure, diabetes prevention, and management. And I'm sure everyone here has one of these. So technology definitely is the wave of the future, and I think that, the easier way we can tap into actually using something that most people have and carry around with them will be very helpful for healthcare in the future. So with that said, I'd like to give this over to Dr. Lindeman.
Thank you very much. I'm delighted to be here and really thrilled when Hattie asked if I could speak on a number of these issues. It was quite, I was very excited to have that opportunity because we've been doing a lot of work in technology. I know you folks are very interested. I love the diversity of who we have here from so many different settings. And we've worked with many of your programs, many of the different settings here in terms of some of the best practices that are out there in terms of technology. So for the next half hour, I'm not only going to try to share with you some of the, sort of give you a flavor of some of the technologies, excuse me, we've been looking at, but also, Hattie and I decided that the risk of putting too much material into one session will break it into two, and that is the first part of the program, I'm going to address not only some of the projects we work with within different health systems, physician groups, different programs that we've seen that are dealing with primarily new technologies to assist in addressing the key issues around the Affordable Care Act, particularly a few that relate to stroke, CHF, diabetes. But then we're going to break and switch gears, and I'm going to speak on to my other passion, which is on technologies to benefit the independence of older adults. Because not only have I been running the Center for Technology and Aging and spending 30 years in that area, but I see that as really indicative of so many of the different opportunities and ideas that we're dealing with, and really affect the population that all of you are concerned with. So with that, again, thank you for the very nice introduction. I can just add to it that over the last 6 years now, I have shifted gears from working in applied research settings. Again, I've been at UC Davis and in charge of the Alzheimer's Diagnostic Center that we have here, been at UCSF in the past, been at Rush University Medical Center, but I've always enjoyed the applied programs. But in each case, we have done very little except for some of our caregiver education and our workforce training programs using technology. But in the last 6 years, I've not only had this opportunity to look at a range of these programs and build out the Center for Technology and Aging, but now work with Citrus, which is actually, and I'll explain, a multi-campus program that is a combination of Davis, Berkeley, UC Merced, and UC Santa Cruz. And how we're bringing together multi-discipline programs together across many different departments, starting with engineers. And I'm the first to say I am not only not an engineer, I'm not a clinician, but it's bringing together of all of these areas that is really the exciting part around technology these days. So with that, I'm going to jump to our first part of the program. And let's see, and Carla will make sure I stay right on it. And I really appreciate the hosting and ability to get this all up and running here. Nothing like technology. The funniest part for me is going to major meetings and we'll have it's when you're up there and you're ready to go and then the technology falls apart. And we can't pull something down from the cloud. We can't, your session just crashes. But so far we'll hope that doesn't happen today. So what I'm doing is going to start first with technologies that relate to this area that you're particularly interested in. But I think it's helpful to get a little background on the two organizations, the types of projects we've done, so that you can get that context. And then I'm going to run in through a series of, not the projects that we've been involved in, the multiple grants, we've done a lot of re-granting through the Center for Technology and Aging, but also then some other examples. And let me just start by saying, this is certainly not exhaustive. This is going to be much more of a quick scan of what's out there. I'm going to give just short snippets of different types of technologies. So if you're interested in digging deeper, please let me know. So I'm happy to drill down with you on any issues. Throw a quick question out if you need to. I want to stop by one so we can have a discussion on these areas. But don't hesitate to ask a little bit further and realize that, again, this is not exhaustive in any way. And second, that these technologies are not an end in themselves. I'll start with this, but I want to end with it. Technology is just a tool to really help us in so many different ways. And so I'm going to reinforce that and look for the ways that we're looking for better outcomes, better access, the triple aims for the Affordable Care Act, but going well beyond that in terms of how it empowers the workforce, how it empowers family caregivers, how it empowers patients. So with that, let's get started. And we'll see if I can get technology to work. So again, first I'll give you a little background on both organizations before we jump into it. And with that, let's see if we have technology success here. Thank you very much. And exactly. So just to give you a little background, Citrus, as I mentioned, is a 4-campus program. It was started 13 years ago under Governor Gray Davis as one of 4 state technology centers with the goal of getting California quickly into the forefront of using technology in different fashions. The primary underpinning for it was making sure that different departments, different organizations, different disciplines could work together. So it brings together people, in our case, for around the healthcare space, from not only engineering, School of Medicine here at UC Davis, School of Nursing at UC Davis, informatics department, on and on here. And at Berkeley, we have colleagues who are also here in the room from School of Public Health, Haas Business School, School of Public Policy, the iSchool. It just continues on, and the same with the other campuses. Tremendous expertise, world-class researchers coming together around these areas. We are just one of 4 initiatives because our colleagues work in these other areas in terms of energy, intelligent infrastructure, as well as now how you can use technology to improve connecting people through data. Our mission, though, is to really look at transformative models of care, things that are not just one-offs or slight advances, but really trying to take it to the next level. And what brought me back to the campus was the fact that we are focusing on the real pain points in the healthcare system, primarily around chronic disease and patient engagement. The key technologies that our center, compared to the other UC centers, works on are telehealth, primarily with Tom Nesbitt's shop here in Davis, but also a variety of passive and active sensors, which you'll see today, and then gaming and apps and mobile health as the other area, particularly with colleagues from UC Santa Cruz. We have a range of different opportunities and mechanisms, ranging from challenges and hackathons and seed grants, because we're funded by the Office of the President, so it comes from across the campuses, but also large proposals where we are engaged with the Corey proposals, CMMI proposals, and a range of other programs, hopefully with CDC, HRSA, et cetera. So my other hat at the Center for Technology and Aging has been funded by the SCAN Foundation from Southern California to help us move in the area of identifying new technology solutions around chronic disease. And in our case, the goal is not just new projects, but to help look at how programs can be scaled. Because I think we've all been involved with pilots over the years. I certainly have, many of which have been very successful, but don't get traction. So the goal behind Center for Technology and Aging has been to work with many organizations, including many in this room, to look at programs that use technology solutions but can quickly be scaled once they've been shown to be efficacious. And we've worked with programs around the country, basically in these 4 primary areas. And I'll give some examples shortly around medication monitoring and adherence, but also looking at the care transition process, particularly related to 30-day readmissions, and then looking at remote patient monitoring, and this is where we really get into stroke, diabetes, CHF, COPD, and new uses of mobile technology. In each case, it's been to advance the efficiency of care, the effectiveness of care. Again, we're looking at new workforce techniques, looking at new ways to manage chronic disease, and ultimately adoption and scaling. Just to give you a quick overview, and then I'm going to give you some of the specific programs, we funded 22 different initiatives that range from local programs here in California to health system-wide programs to those across the country. And I'm going to show you a video of one that actually worked from Connecticut back here to California. Our metric for success was looking at the number of clinical outcomes or program outcomes, as well as their ability to scale. It was very interesting. Each one was different. We didn't go in with a predetermined intervention or program. The programs came to us. It was what fit within their system. What did they need immediately? Many of them were focusing again on the key issues around the Affordable Care Act. And 12 were looking at 30-day readmissions. And as you can see, 10 did very well. In fact, several did extremely well. The results of this are available in our impact report, available on our website. You can tease out the individual information for all of them. But we also saw significant improvements in patient satisfaction. We saw great work around return on investment, which again is a key issue as we're making determinations. In fact, we were supported by the California Healthcare Foundation to build out a return on investment tool for remote patient monitoring. We did this with our colleagues at the Center for Protective Health over in Boston. A tool that can be used objectively to assess whether or not your program is going to have a scalable impact over time. I don't have time to go into that today, but one of the things, again, that we used as a means of saying, were we really having success here? And that was, did these programs not only succeed, but could they be taken to other parts of their health system, or to other states, or even national? And we were thrilled that 10 out of the 22 did have scalability, which is quite a bit more than we usually see in terms of this type of success from programs that are starting in healthcare organizations from scratch. Several are still expanding as we speak, particularly at Dignity Health, Centura over in Denver, and a few, particularly around pharmacy, are still growing nationally at this point. So I'm going to stop for a second and just give you the flavor of one of the programs. And I noticed that we have a lot of pharmacists here and people working in pharmacology. So I'd like to be able to show you the one of the programs and actually have them speak to it. Let's see, of course, can I find it? So this is Connecticut Pharmaceuticals, who, as you'll hear, have built a wonderful program based in Connecticut with their groups, but also really we're doing delivery of their intervention not only in Connecticut but in Southern California.
The beauty of using this technology is that you can take pharmacists who might be trained in providing medication therapy management and link them with culturally specific community health workers in any area of the country to provide culturally specific services to that underserved population. My name is Tom Buckley. I'm an assistant clinical professor at the University of Connecticut School of Pharmacy. And I'm also executive director of a project called PharmNetX, which is a subsidiary of the Connecticut Pharmacists Foundation. This is a group where we brought together pharmacists as a network to provide clinical services to mostly underserved populations. Medication therapy management is a process where pharmacists work with patients and their providers with the goal of optimizing medication therapy for that patient. Our project specifically focused on Cambodian Americans that were underserved. But the Cambodian American population has very poor health status for many reasons. They're victims of torture and trauma from the Khmer Rouge. That has led to rates of depression and post-traumatic stress disorder of over 60%, 5 to 6 times the rates of diabetes, very high rates of cardiovascular disease, 2 to 3 times the rate of stroke than the American population. So in all, just very poor health outcomes. Video conferencing was used because the Cambodian population has reservations about talking about their therapies over the phone. It was very important to have eye-to-eye contact with these patients. So we used high-definition video conferencing technology, and we needed to train the pharmacists and community health workers to look directly into the camera while they're providing that information. And we found that was able to improve the communication, allowing them to open up about their medical histories.
Only have tablet once a day. In the morning.
It's possible for the healthcare provider to come right to the home of the patient by using telemedicine. And it really establishes a more personal relationship, and issues that may not be understood in the office become clearer when people are talking from home.
Using telemedicine or video conferencing, I was able to do face-to-face counseling with these patients, and if they didn't know a medication they were on, they could hold up their bottle and I could read it right on the screen. And I could tell by their facial expressions or their body language if they weren't understanding me, and I could restate what I wanted to convey to the patient.
90% of the population of the educated class died during the Khmer Rouge. So many of the population does not read or write in their own language. So it was important to be able to speak that language to them so they could verbally answer questions that were in a spoken format on screen.
It is challenging getting patients to take the medications properly, and oftentimes it's just because of simple misunderstanding or lack of understanding of a condition or a reason that they should be taking the medication. Sometimes it's cultural.
So we made sure that our pharmacists and our community health workers were trained in the cultural attributes of the Cambodian population to find out what makes them either accept medication and health services in general, what provides barriers for them to seek out care. These patients feel empowered now to talk to their providers for the first time. And now they can go with other family members or go with their community health workers and talk openly about their health care.
If we can keep patients from being admitted to a hospital or going to the emergency room because they understand their medications and their health conditions better, then we've saved healthcare dollars, in fact. So it may seem like it's more expensive, but in the long run, it's really much less expensive to the overall cost of healthcare.
And what the project showed was a dramatic improvement in health outcomes, where patients' drug therapy goals improved from 69% to 93%. But dramatically, from a health utilization standpoint, we were able to show about a $3,000 per patient per year savings in health utilization. From a ratio of what it cost to provide the service to what we saved in health cost avoidance, it was on the order of 5 to 6 to 1. So for every dollar we spent to provide the service, we saved $5 to $6 in health utilization funds.
We need to make sure that the poorest in our community, that the most underserved, that they have access to this right away, that they're not getting the crumbs off the table and waiting until everybody else is served before they have the benefits of this technology.
Again, thank you for letting me share that program with you, but it's just one of several that we found to be